So it's nice to meet you, Dr. Burch. And I think this is going to be really interesting to discuss really what is the role these days for bariatric surgery, given that we have these new wonderful medications that help people lose weight seemingly effortlessly, although I don't think anything is effortless. And I want to pick your brain a bit, but I actually want to start with a case that I just saw this morning. So it's a woman whose body mass index was around 40, and she has poorly controlled or had poorly controlled diabetes type 2. And we put her on semaglutide, and she lost maybe 10 pounds. But more importantly, her diabetes just became amazingly better. Her A1C is now 7. And she came to see us. Her body mass index is 38, and she wants to go for bariatric surgery. Now, what would you tell me to tell her? Would you want me to switch her to tirzepatide to see if she can get more weight loss that way? Or do you think she's a good candidate for bariatric surgery, which is what she wants? How do you decide these days about what should happen to which patients?
Well, Dr. Peters, it's a pleasure to meet you as well. And you have opened a Pandora's box of questions because I think that none of us are extraordinarily clear on what to do on any of these patients. We know that certainly I was looking at some presentations I've given in the last 10 years a few weeks ago. And at one point in my career, I could say things like the only proven durable treatment for obesity is weight loss surgery. In the context of patients who are morbidly obese requiring risk reduction, not for a year or two, but for decades, and not talking about 10 to 20 pounds, but patients requiring between 40 and 60 pounds of weight loss. That was a previous epoch. That was a previous era. We are now in a new one. And it's wonderful, in fact, to have the opportunity to serve so many patients with something other than just surgery. And so sort of to frame that question is the fact that we're not sure. I think that the NIH criteria have withstood what had been the test of time. The NIH criteria, as you know, for bariatric surgery were determined in 1991, and the risk-benefit ratio was weighed around surgery that was then done open. We are now at a greater than 97% adoption of minimally invasive surgery in this country, but for both primary as well as revisional surgeries. We are now in the era of robotics in surgery, which has also improved the possibility of doing minimally invasive surgery. And so when we look back at those NIH criteria, they determined that any patient with a BMI of 40 or greater was at such high risk for cardiovascular disease that even if they didn't have any disease at the time, i.e. if they have no medical diagnoses, don't take any medical medications on a daily basis, they were considered candidates for weight loss surgery back then. The second group of patients were those with patients with a BMI of 35 or greater who had cardiovascular disease, diabetes, sleep apnea, et cetera. And so we've sort of lived under those guidelines for a long, long time. So the patient you mentioned is a diabetic with a BMI that's come down from a BMI in the 40s to a BMI of 38 with utilization of medications. And the question is, when do you decide, at least the question I'm hearing is, when do you decide to to consider that patient for bariatric surgery versus continued medical therapy with the GLP-1 agonists? And it's a difficult question. A lot of the decision making has to do with patient risk. So if a different patient, a little slightly different patient, a patient who's had multiple abdominal surgeries and say has heart failure, those patients probably are a little bit better served by a lower risk option with medications. A younger patient with no surgical risk factors may be better served with an operation, as one of the things that we think about a lot with the medications is the long-term cost. So the cumulative cost over years of being on the medications. may actually eclipse the cost of surgery eventually. And I think that's something that maybe you could help illustrate or sort of help us understand. When people are on these medications, how long do they need to be on them for, and what sort of cost is associated with the medication, not only the prescription but also the monitoring of the side effects of the medication.
Well, let me jump in for a minute about all of these things, because cost is variable, so that, eventually some of these, maybe all of these, will become generic, but we're also having newer agents that give you more and more weight loss. So one of the, I think, thoughts that I have is this is evolving, and it's evolving in the sense of, sure, I can get weight loss with semaglutide, but that generally doesn't get me down, to the target. The patient isn't where they really want to be at the end of whatever the maximal benefit will be. Tirzepatide gives you somewhat more weight loss, but even still, I have patients who clearly are never going to reach a BMI of less than 40, who I think really would benefit from bariatric surgery. But more than that, these drugs do reach a plateau, and people can and do start out eating them, and they start regaining the weight because their sense of hunger comes back. But they also need to take these medications for life. And there are all sorts of disruptions as to why people can and can't get medication. So I so often have people who come back and they say, yeah, I ran out of my Ozempic, or, there was a supply problem, or I went on vacation and lost it. And so there's a problem with something that you have to do every week. And so I think that might make the effect of the medications to some degree less durable. And yet, if someone takes them and gets to a weight that is healthy for them, I think that that's probably a win-win. Now, my other question, though, is how often do you combine GLP-1 receptor agonist in patients after they have bariatric surgery? And maybe I see this more than you do, but I put patients where they have had bariatric surgery. They may have lost 100 pounds, but they're still not at target. And I'm not meaning that their target is to have a BMI of 20. I'm saying a target BMI, in the mid 20s. I will add in a GLP-1 receptor agonist to help with further weight loss. And even though they do slow gastric emptying to some degree, I, by and large, haven't seen a problem in patients who've already had bariatric surgery. What's your feeling about that?
So it's a really interesting proposition. I think that we have to change the way we look at obesity management as being either surgery or medicine. And start thinking about it more as a multidisciplinary approach to a patient's diagnosis. When the diagnosis is obesity, which is a chronic and relapsing disease, similar to cancer, which is a chronic and potentially relapsing disease. For cancer, we totally think it's normal to have surgery plus chemotherapy plus radiation plus targeted therapies. And I think obesity needs to be managed more like that as well. In terms of how do we deal with patients after surgery? So we know that surgery provides a significant bump in GLP-1 endogenously. So it's been well recognized for a long time that GLP-1 goes up fairly significantly after bariatric surgery, sleeves and bypasses. And so part of looking, part of the outcome measures of whether bariatric surgery has been successful or not are fairly well defined in the bariatric surgery literature. We expect that patients who have bariatric surgery, whether that's sleeve or bypass, would have adequate weight loss at 1 year if they've lost 50% of their extra weight. And again, we're going to be talking in different numbers, right? We're going to talk about excess weight loss versus total body weight loss, which is confusing, but to date, we've really used excess weight loss in the bariatric surgery literature. And so 50% of your extra weight has to come off at 1 year to be considered adequate weight loss. So we can start identifying patients who are looking like they're not going to hit that number probably within 6 months of their surgery. So if you can think of it like a growth curve that we use in pediatrics or used in pediatrics, where we would talk about, whether your child is in what percentile the child is in terms of their weight loss. there is such a thing as looking at patients' weight through the year and seeing that they're coming off trajectory. So we're noticing that Mrs. Jones, who should have been at 60% or 50% excess weight loss by the 6th month, is only at 30%. That's an opportunity that we haven't had before. Usually it was, Mrs. Jones, you got to talk to our dietitians. We got to talk about becoming more active, etc. But Mrs. Jones is saying she's feeling hungry again. So until the new medications came about, there was no option for Mrs. Jones. But now we work with our medical bariatrician in our practice, and we talk about starting medications then, with the goal of salvaging the weight loss or hitting that 50% excess weight loss before the first year. So that's one bucket of patients who I think we could work as a multidisciplinary group to ensure long-term success. The other bucket of patients that can benefit are patients who have had bariatric surgery and are 2 and 3 or 4 and 5 years out and now come back having gained weight back. Those patients, it's multifactorial why they've gained the weight back. Sometimes it's the anatomy, it can be psychosocial events, but all of them together can be helped by decreasing hunger. And so I think those are the two buckets to think about in terms of augmentation of surgical outcomes. The patients who are heading towards inadequate weight loss within the first year, and those patients who come back after a long period of absence from the program, and could be their weight loss could be spurred with the use of GLP-1 antagonist or agonists.
I love the way you're thinking about this because I hadn't thought about it in quite this way before. I hadn't thought about the notion of the trajectory of weight loss. So you really can tell at 6 months if someone's going to be at their goal by the end of a year. I mean, that's predictable. Is that true?
Yeah. So, as predictable as it can be, I think there's been a couple of publications, one from the group at Duke that looked at the sort of weight loss curve, but sort of from a publicly available calculator to predict weight loss over a period of a year, the American College of Surgeons, through their metabolic bariatric surgery quality improvement program, MBS AQUIP, has a publicly available calculator to predict weight loss over the span of about a year. And so we've been utilizing that at Cedars to sort of estimate weight loss throughout the first 12 months. And when we start seeing a real divergence from those numbers, that's when we start to act. So, important to discuss that, medication intervention has not been yet indicated in the first 12 months after surgery because the GLP levels should be high. But we're currently designing a clinical trial to sort of answer that question as to whether or not intervention makes sense, and if so, at what time points.
It does make you wonder about all the factors that go into having a person become overweight or obese, particularly obese. It seems to me that it's so multifactorial because the responses to treatment is so multifactorial. But again, you're thinking of this in a way like you're thinking of cancer or some other chronic disease that requires multi-modalities to treat. I think is great. I would actually argue that we can never forget lifestyle in all of this because I think people need to do the things, hopefully, that can keep them healthy, like exercise and eating higher quality food while they're going through surgery and medication management. But I do have a question about how do you look for and treat any kind of nutritional deficiencies? What's your focus and how do you deal with that?
So that's an important question, particularly when you talk about large amounts of weight loss, which now we can say the medical interventions also are causing significant weight losses, 20-30% total body weight loss, which are numbers that had previously been reserved for only bariatric surgery. And so the possibility for nutrition issues now really encompass both medical management as well as surgical management of weight. So we know that the Obesity Society, American Society of Metabolic and Bariatric Surgery, et cetera, have all gotten together to discuss the best way to screen for vitamin deficiencies, et cetera. They have a position statement that's been sort of been re-upped a number of times. But essentially, though, we look for deficiencies in the vitamins every 6 months in the first year after bariatric surgery. Previously, that had been every 3 months, but we realized that we were getting a lot of labs that were normal. And so, as a society position statement, it's been changed to labs twice a year in the first year, if everything's going normally, and more frequently, and once a year thereafter. And so, specifically, we looked for B12, fat soluble vitamins, vitamin D, especially. Anemia is one of the sort of things that's popped up as really important. As you know, as high as 25% of patients who have bariatric surgery will become anemic at some point in the first 2 to 3 years after surgery, having to do partly with absorption, but also just sort of the change in diet, etc. And so that's something we start really looking after pretty carefully after surgery. I think though, with the tremendous success of the medications, we're going to have to start looking for those things in those patients as well.
That's important, and in fact, it probably should be studied because people are losing a lot of weight, and I've seen deficiencies in a number of micronutrients in people, especially if they really have an effect. I had somebody have tremendous vitamin B12 deficiency after he lost a lot of weight on tirzepatide. So I do think that we need to think more like you think, which is, gee, this has happened to a person. Let's see if there's anything we need to correct or worry about. I guess my final question is, there has been some concern about increasing the risk for suicide with either bariatric surgery or these GLP-1 receptor agonist type drugs. I don't know how much it's losing weight itself or the other factors that go along with it, but I certainly think it's important to consider the mental health of patients. And I think as their bodies change and they have to adjust to a new way of eating and being, I think that they need all the help that they can get and some consideration of, is there something that needs to be done to help them? Have you been concerned about this in your bariatric surgery patients, or is not something you guys have noticed?
Yeah, I think that for a long time, there's been a lot of correlations between, I'll just say, surgical treatment of obesity and the rearing up of a lot of issues that had maybe led to the obesity to begin with. Some psychosocial issues, like all change, positive change can still be stressful. And I think if you're sort of take away some of the adaptive behaviors that have been previously utilized to control the anxiety and stress and depression, the things really have a tendency to present themselves. Again, because of the degree of weight loss that's being seen with the medications, I think it's going to be very clearly a similar analogous situation in the medical management of weight, in that you're going to so for some patients, they're going to feel like a thing is taken away that helped them cope with emotions. And so we have, I think, as a lot of bariatric centers do, we have psychologists, we have a social worker. We have support groups that run pretty routinely for the patients. The support groups, it's important that if you're going to run a support group for patients, it should be monitored by a health professional, not run entirely by patients, because it's important to keep people on track and sort of identify warning signs that somebody is decompensating, whether that's with suicidal ideations, self-harm behaviors, which can encompass alcohol and drug utilization, but also some sort of high-risk behaviors that we've seen in patients. I think it's really important that these interventions happen early on, and support groups are a great way to build a community amongst the patients so that they can support each other, but also because it's monitored by a health professional, it's a bit of a screening tool as well to identify patients who are at risk. But as you mentioned, I think that with the tremendous weight loss seen with the medications now, I think the knowledge base is there already in bariatric surgery. I think it's important to share it and really come together with medical bariatricians. to establish a sort of multidisciplinary approach to the problem.
That's a great answer. I think it's so important. And I think you all actually have the advantage in that you seem to be so organized around this. I, as a diabetologist, I'm not used to seeing lots of weight loss except in the setting of bariatric surgery where they have the services and resources you're talking about. In my little clinic, I go, wow, look at that, your blood sugars are better and you've lost some weight. But I think I have to start thinking about it differently too, that I have this tool, increasing tools that are going to allow my patients to lose more and more of their weight medically. And how do I support my patients in this journey? And how do I make sure that they're kept safe and healthy? So I think these were really good points. I've loved talking with you. And I hope we get to work together on some patients and take, good care of them.
That'd be two of us that hope that. I have a couple of questions for you. In terms of, some of the studies have shown, a lot of the studies have shown that people, when they come off the medications, they tend to gain their weight back. But does that happen at the same rate for all the patients? Have you noticed, or has it been reported in the literature that there's certain groups that are more at risk for weight regain after coming off the medications? Whether that relates to BMI or comorbidities. How do you decide which patients need to be on it for life, or which patients are at high risk for recurrence of their weight?
Well, so there is no organized literature around this because all the big clinical trials look at putting you on the drug and what happens. They don't look at taking you off the drug. But in my own practice, and I have lots of patients who are on these agents, is because I really do think that there's so many different responses to these agents and so many different causes for obesity, is that I've seen patients where they can cut back, where if I say take half the dose every week or the whole dose every other week, that they'll manage to maintain their weight on less. But almost no one, in my experience, has weaned off of it and kept the weight off. And I can't tell you who will gain the most weight back, but in most cases, people, in my experience, gain between 50 to 80% of the weight back. But with semaglutide, I think I see less weight loss. And semaglutide, I'm the more used to, and I've seen it for so many years, versus tirzepatide, which gives you even more weight loss. So I'm not sure, as I start getting to know what happens in people who have even more weight loss, what the weight regain looks like. But certainly with semaglutide, people just say their hunger comes back, and if they stop it fast, they're just ravenous. So I always have people taper it. If there's a cost issue affording it or having access, I'll reduce the dose, and some of it's better than none of it. But we don't have good data characterizing who's more at risk for the weight regain. But I bet most people will regain the weight to some degree if they stop their agent.
Yeah, interestingly, I think in bariatric surgery, you've spent a long time trying to standardize approaches to the surgery. That's why there's American College of Surgeons has a standardized approach to accreditation of bariatric centers, which guarantees or strives to enforce quality delivery of to patients and outcomes. Despite all those efforts nationally to improve outcomes and sort of standardize approaches, we've never seen the utilization of bariatric surgery increase above 2% of those eligible. Another way to say that is, of all the patients who would qualify for bariatric surgery in the United States, only 2% of patients seek out bariatric surgery. That means that 98% of patients who really need help aren't seeking it out. How is that working, do you believe, with medication? I think medication has a side effect profile, but it also has a cost issue. Are there any studies looking at utilization of medications and the people who can qualify for it?
You ask such good questions. I don't think we look at the world the way you look at the world, which I think is actually why this is such a fascinating conversation to me, because we're basically giving these drugs for, at least in my world, the treatment of obesity and type 2 diabetes. So that's easy because I basically say, this is going to help you. It's helping reduce your cardiovascular risk. It's once a week. It's easy. It isn't bariatric surgery. It doesn't mean that you have to go to the OR. It really is pretty simple. If you're talking about using a weight loss drug like semaglutide as Wegovy, that's something that's a different conversation because it's just about weight loss. And the barrier, I think, is cost, because a lot of the insurance plans don't cover weight loss treatment, at least in terms of medication. So I think that it's really hard to figure out how many people who would qualify based on weight alone would or wouldn't take these agents. I can tell you that side effects are common, that I certainly have patients who can't take them. And in fact, I hear a lot about side effects. I had one clinic day not that long ago where I saw 3 patients in a row who were either on tirzepatide or semaglutide, and they were either suffering from actually having lost too much weight, or one of them had been hospitalized for some sort of GI problem, and they felt it was due to the tirzepatide and needed help. But these aren't, as simple as here, just take this, you're going to be fine. It does take follow-up. There are side effects, and I don't think there's any one size fits all. I do think acceptance of an injectable agent or maybe even an oral agent would probably be easier for most patients than bariatric surgery because it's not surgery. But I think it's complicated treating people who are overweight and obese because there's a lot of psychology behind it, as you well know. And I try to move gently with people because I don't want them to feel badly about themselves, but I want them to be healthier. And we know the health consequences of obesity.
I think you hit on something very important there, and that is that it's interesting to me how when I talk to patients about their diabetes, they're very open to discussing diabetes, or if I talk to them about hypertension or whatever else. But you talk to people about obesity, and there is a fairly emotional response many times that has to do with the concerns about bias, sort of prejudicial behavior they've experienced in the past. And so I think it is even more complex than talking to patients about things we think are hard, like cancer, et cetera. I think there's a lot of emotional attachment to the term obesity. And so it's, again, advocating for really important here, the multidisciplinary approach to these problems. I can tell you in our experience, we are a department of surgery, but we hired an obesity medicine physician, internal medicine doctor into our department, who is paid for by the department of surgery, in order to ensure that we were approaching this as a sort of multidisciplinary comprehensive center. In addition to that, we've actually started utilizing occupational therapy, who are trained specifically around obesity, behavior management, et cetera. And so I think the field is wide open. And it's funny because I think as a bariatric surgeon, we're seeing a 20 to 30% reduction in volume since the advent of medication, which is big. But it's a thing that I'm welcoming with open arms because of the impact it's going to have on our patients.
Yeah, I was going to say, it's kind of a mixed blessing because you want people to be successful with weight loss no matter how they get there. But my bet is because everybody's getting used to these agents to see how they work in themselves, to see what point they get to, that people will still need bariatric surgery just like they need these medications, and we'll find some balance to it. I mean, I would love to work at the preventive end of all this and to use these agents in people who are not yet significantly overweight and see if I can treat their diabetes and prevent obesity. That would be my dream, is to use this earlier rather than later to help patients, avoid all of these complications and issues down the line.
Yeah, I think part of the, as you know, prescribing the medication when it's not for just diabetes, but it's as Ozempic, is something anybody can do. I think that's important to talk about because, I've seen med spas popping up and physicians who can prescribing the medications without any of the things we've talked about thus far, without goals around A1C if it's a diabetes patient, but also even looking at nutritional impact on patients is something that we as a society of physicians need to sort of really talk about, because I think the potential for abuse is significant, and we're talking about a very vulnerable population of patients who are really willing to turn to anything to lose the weight. And so I think it's going to really be important over the next few years, or maybe even really months, to think about how we as different societies are going to help manage this issue, so that patients who are vulnerable are not getting taken advantage of by people who maybe shouldn't be prescribing the medication, because that might be all they're doing is writing a prescription and walking away.
We need to make sure that everyone takes good care of the patients, because I agree, they've been thousands of different things advertised over time for weight loss. And this one actually works, but I really do believe it needs to be used in a controlled setting, because there are other side effects and things that need to be watched in patients who are on any of these gut peptide treatments. Do you have any closing comments you'd like to make?
The only thing in closing that I'd like to sort of reflect upon is, again, the sort of multidisciplinary approach that we need, that's required to take care of patients with a chronic relapsing disease that's going to be a part of their life for their entire lifespan. We know that the improvement of comorbidities doesn't require a lot of weight loss. Really, 10 to 15% of weight loss is enough to sort of improve all the health problems. But the recidivism of that weight loss and approaching surgery at some point may be an option for some patients. But I really appreciate the fact that people like yourself, who are really committed to ensuring good outcomes, are part of this group. So thank you very much for your time.
Well, yes, and thank you for your time. I've really enjoyed this, and I hope we get to continue the conversation. Thank you.
Thank you.